Goes back to David. Oh, could you pass him the
Yeah.
board? So the answers, and why don't you present Kevin? Are you, Kevin, can discuss it?
Kevin's not here, he had to go to St. Ops.
All right. Who else is here? We could, I don't, try not to do the first year, it's the PGY twos.
It might be the only ones left, but we can just cut them on slide.
They can do this one.
Can they do this one?
Yeah.
Is this not?
Present when I was in PGY too, the first round of.
This is like the first round.
Yes.
All right, why don't we do that?
They're very good.
All right, okay.
It's almost better to go now because there's extremely low stakes.
Do you
Like,
want?
we
It's
can
true.
do-
It'll
we
be
can
nice,
do-
like, oh, that was great. Like you say anything like, wow.
Yeah, if you do good, then that's crazy.
It's like
Yeah, we
preschool.
So
We can do a
this
good one
is,
too.
All right, okay, so once
this is
you pick,
relatively easy.
you wanna pick
based on what
somebody?
we've
Who
done
should we
already.
pick? Some, you guys can pick somebody on
Well,
it.
how about Leah and Tom go together?
Okay, we can do.
All right,
it.
and we'll walk you guys through how we
Okay,
systematically we
Yeah,
that'd be
and
helpful, yeah.
flex in terminology. You can do it. So this is a 63-year-old woman who presented, with vision loss in her left eye that started 2 days ago. She went to the ED, everything was reportedly normal, right eye was okay. She has medical history of thyroid disease, Lyme disease, and exposure to mold. She's on a number of medications, including progesterone, and some vitamins and headache medication. So vision in her right eye is good, normal. It's her left eye that is now affected. She's 2200 at distance, 2400 at near. Pressures are okay. So what kind of photo is this? All right, this is a color fundus photo of the right eye. So we go through systematically, and first we talk about the clarity of the vitreous and what we see. So here's
So the vitreous is
clear
clear.
media. Yeah. Then we go to the nerve. Sharp borders, no pallor of the nerve. And vasculature, you can see that there's no AV crossing changes, maybe, I don't know if there's mild attenuation of the arteries, but no obvious abnormalities in vasculature or in the macula. So normal fundus, color fundus photo. Kind of photo is this,
So this is color fundus of the left eye.
right?
Media is clear.
Mhm.
The nerve, margins are blurred. Basically, you see, tortuous vessels and scattered hemorrhages, like dot blot, maybe some flame hemorrhages.
Anything in addition to tortuosity? Dilated veins? And then there's one finding that I'm not gonna point out that you are missing because it's subtle and it comes up more clearly in other photos. So I'm gonna let you guys.
I think something in the macula.
Yeah,
Looks a little strange to me, but I don't really know
It
what
does.
to call that.
in what way does it look strange?
Like the pigmentation.
Yeah, is it darker or lighter?
Lighter.
Yeah.
yeah.
Good.
I can give you the, here's a, if you want to point with the, this will become sort of an arrow, quest that you can point with it.
So I'm guessing you're talking about this area here.
Yeah.
So, what kind of photo is this? Tough one. Whenever we ask this, the trick is to just look in the bottom left corner.
I don't tell them the tricks.
So this is a multicolor photo. I do
Do you
have,
guys have that here on the Heidelberg?
I haven't seen it at Morrison.
Okay.
No, we
Um,
do, they do, you just haven't asked for it.
No one's ever used it.
Yeah. I'll have a slide on this later. But this is a relatively newer technology for imaging the retina, using 3 discrete, laser wavelengths. And the balance of the 3 is such that it kind of mimics, what a color fundus photo looks like. But the point of using the 3 discrete wavelengths is it gives you, higher resolution detail. And also in terms of resolution, because it's laser, it has a much higher pixel density.
So this is false color.
Yeah, so, well, it's false color, but it's a composition of three
I want
wavelengths.
to say this one might be two. I'm not sure. This one might not have to do. Right, this one might be two colors. This one might, because it looks, when they look greener, they tend to be red, green, and when they get a little less green, they tend to be red, green, but I'm not positive. But
And I think the color is based on, to some extent, what layer the lasers think the thing they're imaging
processing.
is on in their height.
Right.
So it's not real color.
This is kind of the crummiest.
This is why I never
Heidelberg
used it.
multicolor is the worst. The Optos and Claris are all technically kind of multicolors too. But the Optos uses 3 lasers. The Claris actually uses LEDs.
Yeah, I
which is kind
thought
of-
Claris was like true color and Optos
Yeah.
was pseudo color.
They're
Someone said.
3
that.
colors,
I
but yeah,
didn't
the
know what that
Optos with the blue actually, we have the newer one.
Oh,
No, I didn't know that.
They
They
added-
only had 2 when I was.
Yeah, they added a blue, that's why I bought it, but the lashes are driving me crazy. But the Claris and the Optos both now have 3, but this I think has 2. And I think this also manipulates the IR to become red, which doesn't quite swing. So I think they just added a second laser, kind of pushed the IR with some programming to red. But anyway, so good. We don't use them that much. But it does show this.
Yes, so this really highlights that area we were talking about before. There's definitely something going on there. And you can still see the disc hemorrhaging, disc elevation, the retinal hemorrhages, the venous dilation and tortuosity.
See, the nerve fiber layer, that's based on the fact that it's thicker there. And similarly, that area of what I would call edema in the macula is because it's thicker, and that's why it's showing whiter.
And like I said, I'll have a slide later on a little bit of this. Okay. What kind of photo is it? Okay. The IR, yes, so the right eye.
Again, the media is clear.
Sure, good.
All right, so the media is clear. This is not the eye of interest, but the optic disc again is sharp and normal in color. There's no AD changes in the vessels. There's no abnormal discoloration of the macula. And this is the left eye. We're seeing, to comment on the macula.
Code white,
Hyper.
one blood,
So.
and BPAM scanner.
Hyper reflective.
Code white, one blood, and BPAM scanner.
Modeling of the superior portion of the macula.
Sure. Yeah, well, eventually, and presumably I have not done this yet, but get down the right terminology, right? Reflectivity, fluorescence, autofluorescence. It's difficult
And not sinus.
and not sinuses.
I assume it does it all the time, drives me crazy.
So Julia, what kind of photo is this or image?
The OCT.
Which eye?
Look where it's
I'm gonna
thicker.
guess. Well,
So,
I
like,
feel
the
like the
top
nerve
layer?
should be on
Yeah,
the right side.
exactly. So which eye is it? It's wherever it's thicker, that's the eye.
Okay, so that's the right eye?
Yeah,
Yeah.
Okay.
So this
it's
is,
easy OCT.
Nerve.
wherever it's thicker.
also you can look at the RNFL.
Right, the thickness,
Yeah.
yeah.
So it's a normal OCT of the right eye.
Oh, okay.
Maybe some
Okay.
ERM and
It's a
some.
nice looking RNFL.
Okay, so what kind of photos or image is this?
Okay, OCT is the left eye.
Mhm.
We are looking at, it looks like there's a thickening
Mhm.
of the retina,
Mhm.
especially toward in the top of the macular bundle.
Mhm. So definitely some,
And if you look at the definition of the layers, if you go back to the other one, and you look at your macular layers, you see how you see like a layer cake. I always tell my patients to say layer cake, like. And then when you get to the other one, the layers just look different, right? For the center.
so some inner layer thickening.
And reflectivity, it's like a loss of architecture, kind of more reflectivity than you should have.
And then back to this, what orientation is this? Vertical or horizontal?
This is the horizontal cut,
Yeah.
this is the vertical, then assuming of the left eye.
Wait, how?
Yes.
how
Because
do
you
call
can,
that?
if the ganglion cells are thicker, like it's going to the nerve, you know it's horizontal, because it's going straight to the nerve. Versus vertical, that line is not going to the nerve, so with the ganglion layer is the same depth.
It's symmetric, there's no
Yeah.
obvious, like, asymmetry, so there's clearly something going on here. The RNFL is thicker on this side,
So that's
versus
horizontal.
here, the
Yeah.
thickness of the RNFL is the same, there's no nerve.
Vertical.
Yeah,
Okay,
so
Because
there's
if you think
symmetry,
there's nothing there.
okay.
Looking
And-
vertically.
and because there's symmetry, you need to be told which eye this is. This is the left eye, the affected eye. So this is just the vertical OCT, demonstrating what we saw before, just the thickening of the inner neck layers and kind of loss of the architecture and some hyper reflective.
And what was the vision inside?
So 2,200 at distance, 2,400.
That's interesting. So think about the vision, and there's not, is there any macular edema in the fovea? It's a vein, it's a problem. But it's-
Told you, see, that's what he's done.
if you look at the thickening in the middle.
He's already made the diagnosis. He's gonna look for all the signs and interpret.
So why is the vision worse? So anyway, keep that in
So-
the back of your head, like, why is the vision worse?
Yeah. So we know this isn't gonna be normal, but what kind of image is this?
This is the fluorescein angiography of the right eye.
Yes.
This is the AV phase. There goes, yes.
What kind of image?
FA, the left eye.
Mhm.
I'm gonna say, is it AV phase too, or?
Yeah, it's early, it's earlier. Yeah.
Sometimes we call it laminar phase,
Yeah.
because you see the laminar flow in the veins.
Mm.
See we get a little white on the edge, dark in the middle.
So I'm gonna kind of cycle through some things. And I'm gonna go back and forth. Tell me if you see things happening.
So that's the veins filling.
Right.
Mhm. So let's go back. What's the big difference between this and this? So how about that area of the macula that we were looking at before?
I don't know, it looks like the same.
So what kind of vessels are these? Are they arterial or are they venous? They're arterial.
Okay.
And look how long it takes for them to fill. So there's delayed arterial filling. And we go back through and looking at the time, also delayed venous filling everywhere.
Yeah, if you go back to your very first, where's the very first film? Is that the earliest we got? So yeah, the first thing is gonna be, so the arterial fills the middle, looks like a little trident kind of on its side. So that's an arterial. No, I think the one right to the fovea, that guy right there. So that's an arterial. And then if you see later, the other vessel that fills later has to be the vein. There should be a vessel. Yeah, there goes a vessel appearing there, which is the vein.
Mhm.
So, in summary, there's asymmetry between right and left. Left showed lots of retinal hemorrhages, dilated and tortuous veins, and that area in the macula was a little bit more pale. The multicolored fundus photo re-demonstrated that. Had that. I don't know how we discuss those findings in multicolor.
We're not gonna bring them that much. It's more of a lazy thing. When we didn't have color, now we have good color cameras, so I wouldn't worry about the multicolor. The multicolor is super good for looking at macular puckers. It shows because the multicolor on the Heidelberg, which doesn't have the blue, it's green and red. It shows the depths. You see the surface of the retina better, so you can see things on the surface when they're swelling a little more green. But I wouldn't worry about the multicolor.
So IR showed, hyperreflectance in that corresponding macular region. We were talking about OCT showed hyperreflectivity in the inner layers and some increased, thickening in those areas.
I would go reflectivity on the color, like multicolor. If you're, is that what that was your question?
Yeah,
Yeah, I'd go reflectivity.
And then FA, we had, oh, I guess we didn't really talk about that, but these spots of darkening hypo autofluorescence probably blocking from the retinal hemorrhages that we saw. Okay. Delayed transit time, both.
Or you're doing what I did in my lecture. So it's hyperfluorescence. I think the same thing, not hyperautofluorescence.
Delayed transit time, like I said, eventually, presumably, we'll figure out the terminology that we're behind. So there's delayed transit time, diffusely, venously, and in that area that in the macula, there's a delayed arterial time. Okay, so what do you think is going on?
Top differential would be CRVO.
Mhm.
If you could say diabetic retinopathy 2 without the dot hemorrhaging.
Okay, hypertensive retinopathy.
One more. Always give it.
Radiation.
Yeah, there you go.
So what about that delayed arterial filling? So you got a lot of them. CRVO, we can further delineate ischemic, non-ischemic. Like you said, hypertensive retinopathy, anemia. I've included OIS and temporal arteritis. So what's happening is we have that area of whitening you typically see in arterial occlusions. And here's that multicolor really demonstrating that well. So what's happening is you have the central retinal vein occlusion with associated cilioretinal artery occlusion. So going back to those photos that Brian Drucker was talking about, this cilioretinal artery, which is filling the macula, has been occluded by the CRVO. So a lot of this is going to overlap with Grant's presentation, so I'll go through, but the pathophysiology of the CRVO is some kind of vaso-occlusive event, thinking of thrombogenesis and Burghouse triad. So there's endothelial damage to the vein, there's venous stasis, and there's the hypercoagulability. Risk factors for CRVO, age is number one, because it's normal for the age is dead. Hypertension, so the vasculopathic risk factors, hypertension, hyperlipidemia, diabetes, hypercoagulability, like Grant said, folks who are less than 50, you want to think about hypercoagulable factors. Over 50, you don't really need to think about working them up. Interestingly, glaucoma is a risk factor. Didn't come across a great discussion on the mechanism of that, but I imagine that just the increased pressure intraocularly is putting increased pressure on the veins, which just lowers the threshold for having an occlusive event.
No, for CRVO, it's probably the anatomy. It's probably just that your nerve, if you imagine you're trying to, like, if you're playing with your Hot Wheels track or something, or stringing pipe, and, you're going into the optic nerve, and then all of a sudden someone makes you go over a step. The nerve changes to this step and the vessel's got to go over. So I think it's just the anatomy just causes either turbulence, which is kind of fun, or just restricted flow.
And then, so what's going on with the cilioretinal artery? So these are fed by the ciliary arteries rather than the central retinal artery. And there's a very, the choroidal filling pressure is relatively low. And the difference is pretty small. It's just 7 millimeters of mercury difference. So the thought is that
So that's the difference between the choroidal and central artery perfusion pressure?
that's what I read.
Okay.
So the increased pressure in the vein is then compressing the cilioretinal artery, limiting its flow. Epidemiologically, the prevalence is, 0.1%. Various figures, Grant said 70-30, non-ischemic to ischemic. I saw 75-25, so predominantly non-ischemic. Couldn't find much on the coincidence of CRVO and cilioretinal artery occlusion, but by itself, the CLRAOs account for about 5% of all the retinal artery occlusions, and they identified 3 types. In this case, it's the second type associated with CRVO, but it can just be isolated by itself or associated with ischemic optic neuropathy. So treatment for CRVO, immediately there's no treatment for it unless you consider treating the underlying cause. If it's related to hypertension, treat the hypertension. If it's related to diabetes, treat the diabetes, and so on. The name of the game is treating the sequelae of the CRVO. So like Grant was talking about, we think about neovascularization and edema. So the mainstay, as always, anti-VEGF. Interestingly, there's no role for prophylactic PRP. Studies show that it just did not prevent the progression of neovascularization, but there was a role in PRP and laser if it had happened.
And there's some work was done, in the initial CRVO study showed PRP wasn't helpful in the absence of neovascularization. Subsequent to that, there was for a while this thought that as you taper it off, you'd be able to stop anti-VEGF treatment more quickly in patients who you did a PRP on because you would downregulate VEGF with the PRP. And I believe all those studies were negative, that it didn't work. Because I did it for a little while and then I stopped. I don't know, PRP is a pain in the neck, but independent of that, I don't think it benefited the patients, but it made sense that you would do wide angle photography, look for ischemic areas, you do PRP, and then, okay, now they wouldn't get the macular edema because you downlated the VEGF, but it just doesn't do it enough.
But the original paper looked at if you had, 10 or more disc diameters, or maybe it was 30 more disc diameters, I don't know which, they would give prophylaxis, and if those eyes did not, they ended up getting neovascularization.
Didn't do any better. So yeah, so just.
So you have to wait till you see the neovascularization. It never made sense to me, but it was because it didn't make sense, I could remember it.
It's like studying for boards. All right.
So prognosis, for non-ischemic CRVOs, half of the folks, will either be normal or near normal. And AAO pointed out, if you think about the initial vision, that will be a good prognostic indicator. So the 26 or better, likely to be so. In this intermediate area, 2080 to 2200, it's very variable. It could get better, it could get worse, or stay the same, and then worse in 2200, likely to not have improvement. So I guess in our patient, I'm not sure what was happening in terms of the mechanism of the vision loss. Whether
That was a cilioretinal.
right, but how much of the vision loss do you attribute to one of the two things going on?
It was all the cilioretinal.
All cilioretinal.
There's no macular edema. So it's entirely, because if you look at that macula, it was totally dry.
Yeah.
So it's entirely cilioretinal. So there's no reason to do shots in this patient.
Because when you look at it, it doesn't look like the classic blood and thunder. It doesn't look like it would be the ischemic central retinal.
And I think on the fluorescein, there wasn't really any non-perfusion.
No.
In the periphery, other than the macula.
Exactly.
Which is unfortunate. But yeah, in the absence of, and even if there was, in the absence of central macular edema, I don't think you can tag the vein occlusion for the vision loss.
But would the cilioretinal, say you had cilioretinal artery occlusion isolated,
Right.
first time, would you expect a 2400 vision from that?
Oh, yeah.
Oh, it depends on how good their fixation is. People can, it depends on where it is. I mean, it's just that little spot, it's like, how much can you see? Most people can squeeze 2400, 2200 out of an eye. You know, it's remarkable. I'm shocked. My older patients with these giant macular stars, and people see pretty well. They adjust.
They can navigate.
Yeah, it's remarkable. So,
And then, just a comment on the multicolor.
oh, thanks. Yeah.
So like Dr. Paver was saying, each of the wavelengths corresponds to a particular depth of the retina. What we were seeing was a lot of the blue-green signal, like Dr. Paver was pointing out along the RNFL, where it's thicker, on the inner side. So that's why it was a little more blue-green. We were seeing a lot of inner layer thickness on the OCT, which is why it's showing up a little bit more blue and green on the multicolor. So there's some good videos on the Heidelberg website if you're interested.
That's cool.
So, because this is relatively new to me and that
Yeah.
I don't see this all that often, so they're just some good.
Did they say there was more on the website?
Yeah, they were.
Maybe there is. If
I
they-
don't know if there are different functions where you could do 1, 2, or 3 of the
Yeah.
wavelengths.
I think maybe it wasn't on our machine. That's a nice graphic because that's true of a bunch of stuff. So the blue, green, red, so red goes deeper. So if you're lasering something, you can laser deeper with red than you can with blue or green. And also it's true with optics, when you're looking at where things focus and chromatic aberration, the red wavelengths go deeper than the green. That's why they used to do the red. You don't have red-green charts, do you? We used to have red-green charts. If you have red-green charts, the idea was that the red focus is deeper to the retina. And with chromatic aberration, if there's an image with the red part of your image goes deeper, the green part of the image goes more superficial. They used to use that for refining refraction in the old days to pull it closer. So it is helpful. I don't know if we use it.
Boy, that goes back a long time. I haven't
Yeah.
seen that in
With
ages.
the red green glasses.
So to conclude, our patient, 2 months later, visual acuity was the same. I was looking at this fundus photo and I was wondering what was happening.
Hemorrhage,
So is that just
Subretinal.
residual disc?
interretinal. It's,
Yeah, it might have been there and now you're seeing it.
Mhm.
Or it might have been, if you look at the initial images, if you want to scroll back, it might have, sometimes those swollen nerves hide stuff. I've had some people with really funny looking nerves after. Yeah, there might have been the blood was there, but it might have been that he bled later as things settled out.
Mhm.
And became sort of a peripapillary hemorrhage.
do you have a follow-up OCT in the macula?
No, but it would have been atrophic.
Yeah, that's what I was saying.
I can tell you it was, but I don't have it.
The,
Yeah, I always found the Cilioretinal artery, which is kind of fascinating. So there's a 7-point